Know if is the microphone working? Is the mic working? Yeah, it is. Great. It's so good to have you all in. Maybe we can start. And it's 2 o'clock. And we have a plethora of nice speakers. Unfortunately, Dr. Spears from the UK was not able to make it. So the third speaker will not be here. So I'm really thrilled to ask Dr. Chong Is Dr. Chong here? Ah, there he is. Dr. Chong, please come up to the stadium because he's going to tell us everything about the integrative analysis for transcriptomes, because that will reveal precision strategy based on cancer-specific molecular subtypes of bile duct cancer. Dr. Chong.
Thank you for your introduction. And my name is Chong Ui-hyuk. I'm from Korea, Bundangcha Medical Center. And the topic is about integrative analysis for transcriptomes reveal precision strategy based on cancer-specific molecular subtypes of bile duct cancer. I have nothing to disclose. Now, the background of this study is that the bile duct cancer have a heterogeneous tumor entity, harboring distinct tumor biology and clinical phenotypes, unique tumor microenvironments due to its distinct tumor locations like intrahepatic, perihilar, and distal extrahepatic portion. It contributes to its heterogeneity of bile duct cancer. So therefore, we have unmet needs for the precision strategy based on cancer-specific genomic features. The molecular subtypes from bulk RNA sequencing data are suffering from low tumor purity and normal adjacent tissue contaminations. So we need a cancer-specific molecular signature representing tumor biology more precise. Now, there was a study recently, comprehensive molecular subtypes for bile duct cancer were published by a leading research group from Europe. They offered 4 molecular subtypes presenting distinct underlying tumor biology of bile duct cancer. But what they didn't do was that they didn't show the prognostic significance and therapeutic opportunities belonging to their each molecular subtypes. So the aim of this study is to delineate the cancer-specific molecular properties of the bile duct cancer using multi-omics dataset from DepMap project. I'll introduce you at the next slide, and to uncover consensus clusters showing clinical relevance and prognostic significance. And also, we tried to show the potential cancer-specific therapeutic targets, especially molecular targets as a master regulator, as well as targetable compounds of drugs used in other types of cancer right now. So briefly, we used the consensus clustering algorithm. So the data resource that we used was the DepMap project. It was from the Broad Institute, and it contains over 1,800 cancer cell lines. And what they do is they do the genetic screening and cellular modelings and drug sensitivity. And what they do is they try to construct a predicting model. So in easy words, it's like when you take a blood test, so we can screen out the biomarkers or the genes what the patients have, and we can predict what kind of cancer they might have, or if he has already been diagnosed with cancer, what kind of prognostic that the patient might go for. And to evaluate the cellular modelings, which means what kind of characteristic would the cancer have? Is it an aggressive one? Is it a mild one? Will it spread over all to other organs? So we can evaluate those. And for last, we can see what kind of sensitivity the drugs that we can use, so how we can treat the cancer. So out of those over 1,800, there were 40 biliary tract cancer cell lines, so that's the ones that we used. So if you can see here, we used the consensus clustering algorithms and NMF algorithms to uncover the clinically relevant molecular subtypes of bile duct cancer. And we could select the total of 3 consensus clusters from the transcriptomics data. As you can see in this slide, there were 40 biliary tract cancer cell lines. It was clustered into 3 clusters, as the blue one, green one, pink one. And if you see inside each cluster, there are a similarity of the gene expression patterns. But if you compare the clusters on another, you can see the differential gene expression patterns of each cluster. And then what we did was the gene set enrichment analysis for the clusters. in order to identify the tumor biology. So we conducted a gene set enrichment analysis, and as you can see on the plot, the cluster 1 showed a decreased graph on KRAS and glycolysis, which means it might act a very mild cancer or quiescent cancer. But on cluster 2, there's an epithelial mesenchymal transition, very repressed, which means it's like a cancer that has a characteristic that stays at home. It doesn't spread sporadically to other sites. And on cluster 3, we can see that the KRAS signaling and cytokine signaling is very increased, which means it is a very aggressive cancer type. So the next step that we took was to validate the set that we had with an external validation cohort set using the TCGA and ICGC data set. So if you see on the graph on the lower left, the TCGA cohort shows that the cluster 3, the most aggressive one that I just explained, has poorer overall survival than cluster 1 and 2. And on the next graph on ICGC dataset, it still shows that the cluster 3 has poorer overall survival than cluster 1. And the last step that we took was to build up a molecular regulation graph like it is on the slide, and to present a potential therapeutics that what we can use. So on the top of the graph that you can see, there are a few like round shaped ones. Those are the master regulators, and the red written on the below are the therapeutics that might target the master regulators. So in cluster 1, there were a few oncologic therapies or non-oncologic therapies that could be used potentially. And in cluster 2, there were only non-oncologic ones, but interestingly, there were some hormone analogs and opioid analgesics that might be potentially effective to the cluster 2 cancer type. And in cluster 3, the most aggressive one, there were immune modulators that could be potentially used in those kind of cluster type cancers. So in conclusion, the comprehensive analysis using a multi-omics data set revealed precision strategies based on cancer-specific molecular subtypes of bioduct cancer in terms of tumor classification and discriminative therapeutic chances. But we still need a prospective translational study companioned with clinical trials to establish the precision strategy for managing bile duct cancer. This is the end of my presentation, and this is the hospital that I work for. Well, thanks to them that I could be here. And this is the Professor Lee Sung-hwan, who is an MD, PhD, and HPV surgeon as well. And he is the head of this research, and he put me involved and gave me the opportunity to present in New York. Thank you for your attention, and I am pleased to have any questions. Thank you.
Dr. Hugh, thank you very much for a very clear presentation, very difficult and very intriguing data that you have there. So any questions from the floor? I can imagine that a lot of people are on the tip of their toes just to ask them. If nobody's there, is popping up. I was interested, I'm not really sure, were the cell lines commercially available already from patients, recent patients?
Well, the fascinating thing is that the DepMap project is available and accessible in the public. All the high intellects are collected from MIT and Harvard, and is funded by huge corporations like Echicon as well.
Yeah.
And they all put it online. So all we can do is just download these data. And as a surgeon, of course, what we have to learn is how to, roll and handle those data. So that's
not so much my question. I'm aware of that. But do you know where the cell lines come from? Do you know what kind of patients are behind that cell lines?
I'm not actually sure at every detail because there are over 1-800s, but all that I know is it's like...
Do you know that they're all bile duct, or are there also some patients with gallbladder cancer in there?
Oh, they have all sorts of cancers, like brain tumors, head and neck.
No, but but the ones that have gallbladder, biliary cancer.
Oh, yes, it's involved in the 40s that I said.
Okay, and do they all have bile duct cancer or all also gallbladder cancer?
I think I cannot answer that question
That-
right now.
No, but that might be intriguing. And the other thing that I would be interested in, do you know where the patients are from? Are they Western? Are they Asian? Do you know that as well?
No, not as well as that.
Because what we saw in some of the research, there are large differences between the transcriptome of patients originating from Asia and originating, for instance, from Europe. So that might be an interesting second step to look into if you are able to find out where the cell lines are from what kind of patients they are.
Well, I can just carefully assume that it will be based on mostly on the Western countries.
Be.
I think so.
Could be, but I do know that the majority of cell lines that are commercially available are actually not from the Western world. Thank you very much. Any other questions from the floor? Maybe you have a question?
No.
Any other questions? If not so, thank you so much. Thank you so much for your presentation, Dr. Job.
Now we're going to have Dr. Stefan Bittner from Netherlands and the actual 10-year survival after resection of perihilar cholangiocarcinoma. What factors preclude cure?
Yes, thank you very much for that kind introduction. My name is Stefan Buchner, and the subject of this talk is the actual 10-year survival after resection of perihilar cholangiocarcinoma, with specific focus on what factors preclude cure. I'm not sure. There. I do not have any disclosures to make. Perihilar cholangiocarcinoma is the commonest of cholangiocarcinomas, but it's still exceedingly rare, with an incidence of about 2 per 100,000 person years. It's not functioning. I've also. There it goes. It's a cancer with a very poor survival. It recurs often, and 5-year survival after curative intent resection is only 40%. And this is a graph from a previous study we did, and we looked at 9-year survival after curative intent surgery, and you can see that the survival is about 10%. But what remains to be seen is what's the difference between a patient who dies at 1.5 years and a patient who is still alive at 9 years. Now, efforts have been made to classify these patients. The most commonly known is the AJCC classification, which divides patients in the T and M categories, and is moderately successful in separating relatively mild and grave diagnosis, especially on short term. There have also been recent efforts using nomograms, and most recently a genetic subdivision by Memorial Sloan Kettering, in which we were gratefully able to participate. But the aim of this study is to determine the cure rate and to identify clinical pathological factors that preclude cure in the long term. Now, in order to do that, we included patients from 22 centers across the globe. We included patients between 2000 and 2009, so that they had a potential follow-up of 10 years. Inclusion criteria were consecutive resections for pathologically confirmed periodic cholangiocarcinoma, and we used Kaplan-Meier analysis to estimate survival. Patients were defined as cured when they had an observed 10-year survival without known recurrence. Because in long-term estimates the proportional hazard assumption fails, we used a semi-parametric mixture cure model to for some reason it's skipping ahead the slide at some point. So we used that semi-parametric mixture cure model to predict cure. In this study, we were able to include 460 patients. They had a median follow-up of 10 years. You can see this is quite an average cohort for periodic cholangiocarcinoma. Slightly more males, about 60%. Age was below 70 years in 70% of patients. A major resection of more than 3 queen nose segments was performed in 90% of patients. About 1 in 3 had positive resection margins. Positive lymph nodes were observed in 40% of patients, and poor differentiation in about a quarter of patients. survival after curative intent resection was observed to be 30 months at a median, and the Kaplan-Meier estimate for 10-year survival was about 13%. Factors that had a very large effect on observed survival were bismuth stage 4, bismuth class 4, which had a hazard rate of about 1.5. Positive resection margins microscopically, which had a hazard ratio of 2, and positive lymph nodes, which had a hazard rate of 2, and finally poor tumor differentiation, which had a hazard rate of 1.7. So observed cure as previously defined, so 10-year survival and no presence of recurrence at 10 years was observed in 25 patients, about 5% of the total cohort. And as you can see, the factors that had a huge influence on survival were, in those factors, almost no cure was observed. So, for example, bismuth correlate stage 4 cure was observed in 3 patients, which was about 3%. And when estimated with the mixture cure model, the estimate of survival was a 0% chance. And the same is for positive resection margins, which had only 2 patients who were observed to be cured at 10 years. Positive lymph nodes, 3 patients, 2%. And the same goes for poor differentiation. So in conclusions, factors that came close to precluding cure included age above 70 years, bismuth correlate stage 4 tumors, hepatic artery reconstruction, positive resection margins, and lymph node metastasis, and poor differentiation as shown previously. Well, it has to be noted that long-term survival in these patients remains extremely poor. Identification of unfavorable prognostic factors is unlikely to deny resection at this point, but it can instead be used to counsel patients preoperatively, as these are operations that have a large morbidity associated with them, and they can also inform postoperative surveillance. With that, I would like to conclude, and I would like to thank the Biliary cholangiocarcinoma collaboration group, which contributors are listed here. Among whom is Professor Casimir. And if you'd like to join the collaboration, you can shoot us a mail, and hopefully we can work together in the future. As these tumors remain exceedingly rare, and large cohorts are needed to draw valid conclusions. Thank you very much.
Thank you, Dr. Bernard. It's very interesting, the survival rate, the 10 years. It's really good. But do you have any question, Doctor? Do you have any question?
Any question from the floor, maybe? I was intrigued. Go ahead. Shoot.
In your the table at the end, where you're looking at prognostic factors, you have your survival at 10 years with no recurrence. And your full cohort, if you exclude those who had died for other reasons other than recurrence, because one of your factors is older than 70 years. You might have cured that patient and then died of something else.
Well, a small percentage, about 1 in 4 patients, is older than 70 years. But what we see from, obviously this is a multi-center study, which with many included patients from all across the globe. We didn't have the opportunity to look into each cause of death specifically. But what we know from the literature is that when you get biliary cholangiocarcinoma, most patients die of their disease. So that is a shortcoming of the study, but I think still these outcomes are fairly representative.
No, but it is important. It's a really important issue, because if you're old and you don't know, I mean, if it's 84 and the chance of being alive for 10 years is smaller than when you're 54. Absolutely right. What's new? What's new in your study? What did you find that was not already there in the literature? It's a large cohort. It's a nice collaboration. What's new?
Well, not so much. We knew these factors were risk factors and that they had a poor effect on survival, but that it is this exceedingly poor, I'm not sure it was really known by many. We have a cohort of almost 500 patients, and what you see after, so patients that were resected with curative intent, and what you see is that patients with positive resection margins, only 2 of those are alive at 10 years, at the 10 years mark. I think that's good to know. These are large operations. These patients have many comorbidities after the operation. I think it's interesting to see that it is that poor.
It's incredible that 10-year survival in a correlate for bismuth.
It's very, yeah, but it's nice. I mean, we sometimes you pass upon a patient. Are you sure that they are all cholangiocarcinoma? We had that same discussion, of course, with pancreatic cancer. If patients survive really, really long, sometimes
these were all pathologically confirmed cholangiocarcinoma. So yes, we do know that for sure within reasonable
doubt.
Yes.
Okay. Any other questions from the floor, maybe? If not so, thank you so much,
Thank
Dr.
you very
Butt.
much.
So as I told you earlier, the third presenter couldn't make it from the UK. Dr. Spears is not able to come. So I call upon Francesco Ardito from Italy. He will tell us that you have to refer a patient early to avoid malpractice litigation if you make a bile duct lesion. Dr. Ardito, go ahead.
Thank you, Chairman. So my focus is on risk factors associated with malpractice litigation for bile duct injury following cholecystectomy. Okay. We know that bile duct injuries are dangerous complications of cholecystectomy with an incidence between 0.4 and 1.5%, and are associated with severe postoperative sequelae in terms of morbidity, mortality, and also long-term quality of life. And it has been estimated that in Europe, about 20–30% of patients with BDI are involved in litigation claim. This is a retrospective observational study, including patients treated at our tertiary care center with BDI during cholecystectomy between 1994 and 2016. So the inclusion criteria were at least 5 years of follow-up, and of course, patients who agreed to participate in a telephone questionnaire focusing on malpractice litigation. BDI were classified according to the Strasberg classification, and we divided severity grade 1, that are BDI without discontinuity of the biliary tree, so lateral injuries, and severity grade 2, that are axial injuries with discontinuity of the biliary tree. Then we assessed the results of treatment at our center according to the patency grade, also by the paper of Professor Strasberg. Grade A was primary patency achieved, and B to C were patients who failed to achieve primary patency or in the treatment period, or who subsequently lost patency. And then we have the worst outcome, grade D, patients who never achieved patency or lost it permanently. So between 1994 and 2016, we enrolled 210 patients with BDI. 4 of these died for septic complications after referral, but before starting any type of treatment, so of course they were excluded. About 40% of patients did not agree to participate in the questioning, so we had an agreement of about 60%. And 27 patients were excluded because the referral time was more than 1 year, so we had 98 patients. This is the type of BDI of such patients, and you can see that about 70% of these were types E. And severity grade 1 was 25%, and severity grade 2 was 75%. Intraoperative diagnosis was performed in about 40% of cases, and attempts at repair before referral at our center were performed in 72% of cases. Overall surgical attempts in 45% of cases, mostly intraoperatively, and endoscopic and percutaneous attempts at repair in about 46% of patients. Of course, several patients underwent both surgical and endoscopic attempts at repair. with several numbers of ERCP and PTC procedures. At our center, 58% of patients underwent surgical repair, mostly hepatogenosis with the hilar plate, then 33% ERCP, 6% PTC, and 3% observation. Of course, our policy was to perform surgical repair in BDI severity grade 2, so with discontinuity of the common bile duct, that was significantly higher than the endoscopic repair that was more frequent in BDI severity grade 1, so in lateral injuries. The median interval time between cholecystectomy and referral was about 18 days, and the median interval time between referral and surgical repair was 46 days. But of course, this interval time varied significantly according to the presentation of patients, because jaundice patients were repaired earlier, 18 days, and of course, patients with biliary fistula and with biliary peritonitis were repaired significantly after several days.
42 days.
The median follow-up was more than 100 months, and you can see that 85% had a patency grade A. This grade A was not significantly different according to the type of management, surgery versus endoscopic or percutaneous. 37% of patients initiated malpractice litigation. At the last follow-up, 83% of these were closed cases. 87% of these had a verdict in favor of the plaintiff, with a compensation in favor of the plaintiff, with a median compensation of 90,000 euros up to 600,000 euros. We divided patients according to the median interval time between cholecystectomy and referral to our center. So we had early referral group, less than 20 days, and late referral group, more than 20 days. And you can see that differences according to the type of injury, according to the Strasberg classification, were not significantly different, except for type A, but the severity grade of BDI were similar in both groups. But, of course, the overall surgical attempts at repair before referral, endoscopic attempts at repair before referral, the number of ERCP procedures before referral, and, of course, the interval time were significantly higher in the late referral group. The type of treatment at our center was not significantly different according to the referral and also the patency grade. So we used we artificially balanced the two groups using the stabilized inverse probability therapy weighting, and we performed a propensity score with the dependent variable that was malpractice litigation, so yes versus no. Then we used 13 covariates according to male, age, severity of BDI, and of course the intraoperative surgical attempts at repair, endoscopic attempts at repair, and the need of surgical repair at our unit. And you can see that differences according to these covariates in the groups were moderate and considerable in most groups. So after the IPTW, you can see that we had very small differences in the two groups, so we proceeded with a multivariable logistic regression analysis. And you can see that the severity grade of BDI, the associated vascular injury, and the need of surgical repair at our center were strong prognostic factors for medical malpractice litigation. But these are factors correlated with the severity of injury. Then we had other factors correlated with an improper postoperative management that are intraoperative surgical attempts at repair before referral, endoscopic attempts at repair before referral, and moreover, the interval time between cholecystectomy and referral to our unit. These are three strong prognostic factors for malpractice litigation that are correlated with an improper postoperative management, not related to the severity of the injury. And you can see that more was the time interval from cholecystectomy to referral to our unit, more is the rate of malpractice litigation in such patients. So in conclusion, we can say that about 40% of patients with BDI initiated malpractice litigation. Of these, 90% of verdicts were in favor of the plaintiff, and with the consequent significant payouts up to 600,000 euros. The improper postoperative management, that is delayed referral, attempts to repair before referral, was one of the strongest predictors for litigation. And considering the number of cholecystectomy performed worldwide, BDI may occur during the surgical activity of a general surgeon, so surgeons must be prepared to manage this surgical challenge, and of course, prompt referral to tertiary referral centers without any attempts at surgical repair are of course, the strongest predictor to avoid malpractice litigation. Thank you.
Thank you so much. Very intriguing data again. I was really wondering, that was really long. The median time to referral was about 18 days, right?
18 days, the median time, yes.
It's very long. Do you have any comment on that?
From cholecystectomy in other
Yeah.
hospitals, yes, to our center. Yes, of course.
How is that?
So up to 90 days and so on. Yes.
Yeah. Do you have any explanation for that high?
Because they are correlated to the attempts at repair in the other centers.
So the other centers...
They underwent surgical repairs, failure, then endoscopic repairs, failures, and then, of course, a delayed referral.
So you don't have a tradition where you have to refer a patient at the moment that you make a bile duct injury to a tertiary referral center.
Yes.
You're allowed to do that on your own in the smaller hospital.
They are allowed. Yes. Yes.
Yeah. Okay.
Yes.
Okay.
Yes.
Okay. Should you change that? Should that be changed?
I think that collaboration with the hospital and in the near territory of the hospital, and of course the promotion of webinars and so on is very important in order to, because the first action is to try to resolve the problem in the hospital without also explaining to the patient the real problem. And of course we are a tertiary referral center, so there is the bias that only the failures are referred. But
how did your Italian colleagues react the moment that you gave them those numbers? What did they say?
No, I think that is a mode to promote the referral to our center, because the real problem is the post-operative management, not the injury.
Exactly.
And many times the severity of injury increased after this type of treatment, not after cholecystectomy.
Just put a drain and refer.
Yes.
Yeah.
Yes.
Okay. Any questions from the floor? Should. Yep. Stand up and.
Something that in Italy we don't usually see. So this could be another thing maybe to promote. So if you don't know what to do, just stop and don't try to dissect where you don't really understand the anatomy. So maybe it's a way to avoid the injuries. I mean, at least this is what the UK system say.
Yeah, it's really intriguing. And what you say is, I mean, it's really important to bring out that message that if it's too difficult, stop. And if you make an injury, just put a drain and refer the patient. Really interesting. Any other questions?
Comment. In American Latin, we have a problem here with the litigation. Is the promotion that the surgeon that received the patient gave to those patients? So you motivate that.
Yes.
And it's really hard. I don't know, in Italy, that's one. And the other one is the bad communication from the surgeon to the surgeon that made the cholecystectomy to the patient.
Yes.
So it's important,
It's an important
because
point, yes.
in American Latin, that's the main thing for that.
Yeah.
And the referral time is impressive. That is too long.
Yes.
Wow. Thank you. It's
Thank you.
really good.
Thank you.
Shall we proceed?
Yes, we're going to proceed with Dr. Ron Perry from the United States. Laparoscopic versus open liver resection for gallbladder cancer and intrahepatic cholangiocarcinoma. The Mayo Clinic experience.
Hi.
Hi.
Hi, my name is Ron Perry. I'm a HPB fellow at Mayo Clinic. I would like to thank the committee for allowing me to present our study regarding retrospective comparison of laparoscopic and open liver resections for gallbladder cancer and intrahepatic cholangiocarcinoma. I have nothing to disclose. So as you all were aware, minimal invasive liver resections and mainly laparoscopic resections have gained worldwide acceptance and popularity gradually in the last 2 decades. But despite that, still minority of cases, less than 20% of liver resections are being done in minimally invasive fashion in North America. Among these, we talk mainly about small non-anatomical wedge resections and left lateral sectorectomy. And when we talk about the malignant indications, the vast majority of cases and data relates to hepatocellular carcinoma and colorectal liver metastases. However, when it comes to gallbladder cancer and intrahepatic cholangiocarcinoma, the data is far more limited and more controversial, and many surgeons are hesitant and reluctant to consider it given the more challenging nature of this procedure with larger resections, margin issues, and the need for portahepatic lymphadenectomy. So the aim of our study as being a high-volume center of minimal invasive liver surgery was to assess the safety and oncologic adequacy of laparoscopic liver resections for these indications. And we looked back at our database and extracted all the cases who had liver resection for gallbladder cancer or intrahepatic cholangiocarcinoma in just a bit more than 5-year cohort between January 16 and April 2021. And we, all laparoscopic cases that were included, and then we frequency matched open cases based on age group and type of tumors in approximately 1-to-2 ratio. And our primary outcomes were 90-day postoperative morbidity, recurrence and overall survivals at 3 years, and some short-term potential benefits such as length of stay, readmission, and reoperation related secondary outcomes. Our median follow-up was 15.5 months. So starting with the clinical preoperative data, overall we had 32 patients who had laparoscopic resection and 52 had open resections. The median age was 65 at the laparoscopic arm and 68 at the open arm, and both groups had 60% female patients. Patients who had laparoscopic resections had significantly higher median BMI of 31.6 versus 29, and there were no differences in preoperative ASA score nor preoperative CA99 values preoperatively. Then we looked at the operative details, and not surprisingly, patients who had laparoscopic resections were less likely to undergo major liver resections defined at 3 or more anatomical segments comparing to open resection, 61%, and that was significant. And then the median operative time was pretty similar, somewhere between 3 and 3.5 hours in the two groups. And patients who had laparoscopic resection had significantly lower median estimated blood loss, 250 versus 475 milliliters. Then we looked at the postoperative course and the complications. So the median length of stay was significantly shorter. Again, not very surprising, although very significant, half actually, 3 days versus 6 days. And when we looked at the rate of severe postoperative complications defined as Galvin-Dindot score 3 or more, there were no differences between the treatment arms, and nor there were any differences in the readmission and reoperation rates between the laparoscopic and open group. Looking at the pathology, we looked first at the tumor size, and although there was no significant difference between laparoscopic and open resections, there was a non-significant trend for larger tumor in the open group with a median size of 53 millimeter versus 35. Overall, our tumor margins, the negative tumor margin rate of our cohort was very high, 94% overall, and there was no difference between the group, nor there was any difference in the T-stage nodal status and the lymphovascular or perineural invasion rates between the patients who had laparoscopic or open resections. The only difference was that patients who had laparoscopic resections were more likely to have well-differentiated tumor than those who had open resections. Then we looked at the adequacy of the portahepatic lymphadenectomy. There was no significant difference in the median number of harvested lymph nodes, 4 in the laparoscopic group and 5 in the open group. And then, as you know, the AJCC 8th edition guideline recommends harvesting at least 6 lymph nodes for proper staging. And then we looked at the rates of proper 6 lymph node lymphadenectomy, again, no significant difference between the group with 67% of laparoscopic cases reached the minimum of 6 lymph nodes and 45% of the open. So overall, lower than expected, but not different. When we looked at the systemic treatment, most patients in both groups got some kind of treatment, either as neoadjuvant, adjuvant, or perioperative fashion, but still patients who had open resections were more likely to receive some kind of systemic treatment. 77% of the open cohort got some kind of systemic treatment versus 66% in the laparoscopic group. This is the long-term outcomes, Kaplan-Meier curves. To the left is the recurrence-free survival, 3 years, and to the right is the overall survival. The blue lines marks the laparoscopic group, and the red lines marks the open groups. And as you can see, we did not find any significant association between surgery type and time to recurrence or death. So clearly, the main limitation of our study is the inherent selection bias of every retrospective comparison of open and laparoscopic resections. So sample size limitation prohibited us from simultaneously adjusting all potential confounders with type of surgery and recurrence or survival. So as a compromise, we ran a series of bivariate hazard regression analyses, adjusting potential predictors of outcomes such as resection margin, nodal status, CA99 levels, tumor size, etc., with type of surgery and recurrence and or survival patterns. And still we did not see, as you can see, with none of them, there was significant association between type of surgery and time to recurrence or to death, although our modest sample size resulted in pretty wide confidence intervals, as you can see. So the main limitations of our study was, as I just mentioned, mainly the selection bias of the patient. We had a relatively short follow-up, and unfortunately we did not include robotic cases, which gaining more and more acceptance and obviously will play a role in the future. So to sum up, when done by experienced minimally invasive surgeons and with proper patient selection that still needs to be determined, laparoscopic liver resection for gallbladder cancer and intrahepatic cholangiocarcinoma are feasible, are safe, and are likely to be non-inferior and oncologically appropriate as open surgery, again, with proper patient selection. And we need to do a better job with the lymphadenectomy, but that is true both for open and laparoscopic resections. I would like to thank Dr. Sean Cleary for mentoring me in this study and the rest of the group at Mayo Clinic. Thank you.
Any question? Any question from the floor? Yes, stand up.
Thank you very much. Thomas from Stockholm.
Speak up.
Oh, sorry. Thank you very much for a nice talk. My name is Thomas Jansson, from Stockholm.
Thank you.
Were there any incidental cases, or were all stage oncological patients?
Good question. Yeah, we had, just for the interest of time, I could not go into that, but we had 6 patients in the laparoscopic group and 7 patients in the open group that had completion hepatectomy after incidental finding of simple laparoscopic cholecystectomy. We extracted them from the size analysis, but yeah, there was some 6 and 7 patients.
Thank you very much.
Thanks.
Yes, because that would be the ideal patient to start with, right?
Exactly.
In most cases, because
Yeah.
that is done that could be done laparoscopically quite nicely. I'm not a. It's difficult to interpret your data. I mean, it's not that difficult, of course, but that bias is so difficult to overcome. So you show that the survival is the same, but you also show that there's a considerable bias. So how would you? What could you do to show us a little bit more, to give us a little bit more confidence that this is really the way forward?
Right. So basically, I think it's a matter of numbers. If we do like multi-institutional work, it's always gonna be probably retrospective, right? So if we get higher numbers, we can do more kind of multivariate analysis, and then hopefully forever there will be some kind of selection bias that we cannot overcome, but it will probably be able to minimize that. With higher numbers, multi-center studies,
But the goal is not to operate laparoscopically. The goal is to treat the patient.
right?
So it should be better, right?
Yeah, of course. But this is what this study is trying to find out.
Yeah,
Are
I
we
understand.
compromising on patient care if we're doing minimally invasive or not, right? So that's, I don't have a clear answer. I think it's, you know, according to this, with these limitations, there's still much to learn and to study, but I cannot say that at least maybe in selected cases it's not non-inferior to open resections.
Okay.
You are comparing laparoscopy versus open, right? Surgery, but I don't understand where the systemic therapy has something different with the abordage, you know?
There's no difference. I just wanted to adjust it because that could be also kind of obviously affect the outcomes. So if I would find out that most patients with open resections had some kind of systemic treatment, then likely they had more advanced tumors, which obviously will correlate with the outcomes.
Yeah.
Okay.
So this is why we addressed that. If that answers your question.
Okay, any questions from the floor? If not, then what did we learn today? We learned that transcriptome can help to perform precision medicine in patients with bile duct cancer. Interesting. Thank you so much, Dr. Perry, for your talk. The other thing that we learned is gallbladder cancer can be done laparoscopically. Bile duct injuries should be referred early to avoid litigation. And when you're old, you have a R1 resection, positive lymph node, or bismuth 4, you die early from bile duct cancer. Thank you so much. This concludes this session. Thank you for being here. Thank you so much.
Thank you. Doctor.
You did good. Was it your first time?
Yes.
It showed. No, it did not show at all. Very nice.
Thank you.
Are you going to stay?